Good morning, everyone, and welcome to our virtual cardiac rounds. It will be presented by our esteemed colleague, Dr. Paul Galawango. This morning, he will be presenting on cardiac CT angiography beyond stenosis assessment. Good morning, Dr. Galawango, and it's all yours. Thank you.
Thanks a lot, Chris. Good morning, everyone. Welcome to Division Rounds. I'm going to talk about cardiac CT and just give a bit of an update as to where the field is heading and some of the contemporary developments in terms of coronary artery atherosclerosis with CT angiography. So there's a fair bit to cover, so I'll dive right into it. The objectives for the talk this morning are to describe the role of cardiac CT for assessing coronary plaque extent as well as plaque characteristics, to examine the evidence for cardiac CT as a risk stratification tool beyond just stenosis assessment, and then to review the high-risk atherosclerotic features that can be identified on CT imaging at the current time. No relevant disclosures for this talk. And so, as I'm sure most of you are familiar in terms of the bread and butter of what cardiac CT tends to get ordered for these days, is for symptomatic patients where it's not clear whether the symptoms are due to cardiac ischemia or not. We tend to order contrast CT angiography for stenosis assessment to basically rule out obstructive coronary artery disease. And here you see a picture of a CT image of a proximal RCA stenosis that corresponds quite well with a subsequent coronary angiogram. And then for asymptomatic people, we sometimes will order non-contrast calcium scans as a risk stratifier to see if people are actually higher risk than we might think clinically and might benefit from primary preventive therapy. And here you see dense calcification in this LAD on this calcium scan patient. In addition to mere diagnosis, both these modalities have been shown to have prognostic importance. So for symptomatic patients, it was shown definitively in the CONFIRM trial that the greater the extent of obstructive coronary artery disease, going from single vessel to double to triple or left main, it confers worse prognosis, similar to the cath lab data from invasive angiography. And on the right, you see here data from the MESA study, which was the multi-ethnic study in atherosclerosis, looking at the prognostic importance of calcium scoring. And basically, the more abnormal your score is, so the higher the Agatston score, the worse the long-term prognosis. On the flip side, a normal study with a calcium score of 0 is associated with a very low event rate, even out to 10 years. So these are the traditional ways that CT has been used, and it's probably the most common indications we get today. But what are some of the emerging roles for this modality, and where is it going? And this is what I wanted to touch on today, particularly with plaque evaluation. So cardiac CT evaluation atherosclerotic plaque, I want to touch on 4 modalities or 4 domains. So one is plaque morphology and composition. Another one is overall burden or extent of plaque. Another one is assessing the inflammatory status of plaque and the coronary vessels, and then evaluating the impact of medical therapies on atherosclerotic disease and how can CT help with this. So let's start with looking at plaque morphology and composition. Multiple studies now have been published in literature that show that there are certain adverse plaque features that can identify plaque that are more likely to represent thin cap fibroatheroma, which are the type that tend to result in plaque rupture and acute coronary syndrome. And the presence of these plaque vulnerability features actually improves the risk stratification beyond just severity of diameter stenosis alone. And you see these outlined in the diagram. So the 4 well-described features are the following. So low attenuation plaque, and that attenuation refers to the Hounsfield units associated with the plaque when you measure it with the software. And so if your average attenuation in your plaque is less than 30 Hounsfield units, that's low attenuation. And the reason that's felt to be high risk is that it tends to correlate with areas of necrosis. So a necrotic core is what's going to give you that low attenuation. Secondly is if you see positive remodeling, so an outward bulging of the vessel at the area of the plaque with the index of greater than 1.1, that's also a higher risk feature. Third is something called the napkin ring sign. And that's where you have an area around the lumen where you've got an area of dark and then surrounded by a high attenuating bright rim, which indicates intraplaque hemorrhage. That's a high risk feature, and that's well described as well. So that's the Knapp-Bruggen ring sign you can see on the short axis when you analyze plaque. And then if you've got spotty calcification, so basically an island of calcified dot inside a soft plaque core, that's also a high-risk feature. So when we see plaques that have one or more of these features, we typically refer to them as high-risk plaque or vulnerable plaque. And they have been found to correlate with subsequent or increased risk of subsequent plaque rupture events. So on the left, this figure is looking at data from the Netherlands, looking at patients strictly with non-obstructive CAD on their CT angiograms. And what they found was if you had 2 or more high-risk plaque characteristics, it correlated with increased risk of adverse events. And so you see this is event-free survival on the y-axis. So on the blue line is less than 2 high-risk features, and then 2 or more, you see a lower risk, a lower incidence of event-free survival. On the right, this is a sub-analysis of the PROMISE study, which is a large study looking at 2 different strategies for treating stable outpatients with chest pain and suspected coronary disease. One was stress imaging. The other one was a CT angiogram-derived strategy. And they found in that study that the 2 were equivalent, but when they did a sub-analysis on high-risk plaque features, what they found was the risk of MACE was significantly increased if you had evidence of high-risk plaque on your CT angiogram in the plaque assessment. The Scott-Hart study was similar to the PROMISE study. Again, it was looking at 2 different strategies for dealing with people with suspected chest pain in a stable outpatient setting. So it was standard care versus standard care plus CT angiogram. And there was a post hoc analysis of this study that looked at the impact of plaque morphology, extent, and prognosis. And again, here you see the vulnerable plaque features. In D, you've got the Knapp-Bruggen ring sign. C, spotty calcification. B, you've got a low attenuating necrotic core there, less than 30 Hounsfield units, and you see a positive remodeling segment in A. So in this analysis, they had 1,769 patients, all with CT angiography and chest pain, who were followed for 5 years. They were investigating the prognostic impact of adverse plaque characteristics, and their outcome of interest was cardiovascular death or non-fatal MI. What they saw was in about a third, there were adverse plaque features present, and patients with these adverse plaque features had more risk factors, tended to have higher calcium scores, and they found that MACE was 3 times higher in patients with adverse plaque. Also, if you had the combination of adverse plaque plus obstructive disease, there was a 10-fold increase in the incidence of MACE over those 5 years. Interestingly, when they did multivariable analysis, the only thing that remained a significant predictor of cardiovascular death or non-fatal MI was coronary artery calcium score. So there was no difference in the risk of events in patients with or without adverse plaque features, with or without obstructive disease, when their calcium score was greater than 100. If you had a low calcium score, so less than 100, those with adverse plaque then did have increased risk of events. So it seemed that once your calcium score got higher, it seemed to be the more powerful prognosticator and outweighed all other features. And this was an interesting finding because calcium scoring up to this point had always felt to be mainly of prognostic importance in asymptomatic patients for primary prevention risk stratification. So this found that calcium scoring was a prognostic value even in symptomatic patients. And the thinking is probably because it reflects the total atherosclerotic plaque. So as calcium score goes up, both your amount of calcified and non-calcified plaque is going up as well. So it's a surrogate for total plaque, and that's probably why it's the most robust risk predictor. But again, when your calcium score was lower, adverse plaque features did significantly increase risk of events. Now, the ICONIC trial was an important study that was published in 2018. It was a sub-study of a larger multi-center trial called the CONFIRM study. And so in the ICONIC trial, this was a case-control sub-study of patients who had an acute coronary syndrome after their baseline cardiac CT scan. And they looked at non-event patients and they propensity matched them with the ACS patients in a one-to-one fashion, matching them for risk factors as well as extent of obstructive coronary disease, so single vessel, double vessel, triple vessel. So what you ended up was 234 pairs of ACS and control patients. And in this study, they found that percent stenosis, high-risk plaque features, are not very sensitive for predicting ACS. And so because again, most culprit lesions were non-obstructive and they didn't show high-risk plaque features. So when you see it, it's worrisome, but it's not necessarily predictive, and it sort of makes the case that perhaps these high-risk plaques are more identifying a vulnerable patient who's prone to plaque rupture events in the coronary vasculature, as opposed to vulnerable plaque. In other words, local treatment or local therapy of a high-risk plaque probably won't modify downstream events much because again, these are not necessarily that predictive. So the thinking is there's probably a lot of subclinical rupture and healing of these high-risk plaques, and they don't all cause heart attacks. And that's why one particular one doesn't necessarily have a high predictive value of causing an ACS event, but we know that people who have them tend to have MACE more often. So they're probably identifying a phenotype or a perhaps inflammatory milieu where they're prone to have events, but it's hard to pinpoint if it's going to happen in one particular plaque. Now, what about plaques that are highly calcified? So this was another sub-analysis of the ICONIC trial. And here they were looking at plaques with dense calcium. So Hounsfield units go up the greater the calcium is because the attenuation is greater. So the higher the number, the greater the attenuation, the higher the calcification, the higher the score. So they're looking at people who've got a Hounsfield unit score of greater than 1,000. Now the cutoff for calcium on CT attenuation is about greater than 130. So greater than 1,000 is a really densely calcified plaque. And so what they saw in this sub-analysis was that patients with ACS had significantly more necrotic core. So this was low attenuating plaque, less than 30 Hounsfield units, as well as fibrofatty, so 30 to 130. So that's basically soft plaque that's not necessarily necrotic, but hasn't got to the threshold of calcification. And then if you had, and they looked at those who also had plaque of greater than 1,000 Hounsfield units. And what they found was that on a per patient and per lesion basis, highly calcified plaque, so greater than 1,000 Hounsfield units, was associated with lower risk for future ACS. So if you look at this graph, you're seeing in the dark blue are the ACS patients, light blue are the control patients. And so when you've got necrotic core, so low attenuating plaque, less than 30, this is significantly more represented in your ACS patients, as is your soft plaque that is not necrotic but still not calcified. So basically, all your non-calcified plaque tend to be overrepresented in ACS patients. Or on the flip side, the other extreme, people who had very dense calcified plaque, so greater than 1,000 units, that was overrepresented in the control patients and found to be less often present in your ACS patients. So it seems like highly calcified plaque is more stable, protective, less associated with ACS, where conversely, soft plaque, especially low attenuating plaque, tends to be more associated with ACS events. As opposed to looking at plaque morphology, what about the extent or burden of coronary plaque, and how does that play out in terms of prognostic impact? Well, right now, if you look at how CTs are reported and interpreted, we tend to interpret them much in the same way as an invasive cath, and we focus principally on diameter stenosis severity. And even the Society of Cardiovascular CT guidelines recommend using the CAD-RADS format in your template as a standardization tool. And you can see the legend for CAD-RADS. It's again based on diameter stenosis, where a score of 0 has no stenosis, 1 is minimal, 2 is mild, 3 is a moderate stenosis, 4 is a severe stenosis, where 4A is in a single or double vessel, and 4B is high risk, where it's triple vessel or left main, and then 5 is occlusion. Now, of course, one of the advantages that we should exploit of CT over cath is the ability not to just visualize the lumen, but also to visualize atherosclerosis in the vessel wall, which is not well appreciated on cath if you're not using IVUS. So the extent of plaque can be assessed by both semi-quantitative scores or by quantitative automated software analysis in CT. And research has shown that this is becoming more and more helpful tool. So one of the simplest ways to assess plaque extent is a semi-quantitative score called the segment involvement score. And it's just an expression of plaque extent where basically every segment of the corneal tree that has plaque is given a score of 1, and then you basically just sum them all, and that's your segment involvement score. So it's very easy to do. And it doesn't matter the extent of severity. If there's any plaque at all, it gets a score of 1. So a segment involvement score of 4 or less is felt to be limited plaque burden, whereas 5 or more is extensive plaque. And it's been shown in multiple studies to have independent prognostic value. In our reports at SHN, we do report segment involvement score in addition to the CAD-RAD score to give a sense of plaque extent in addition to diameter stenosis severity. On the diagram here is data from a study that came out of the Brigham and Women's Hospital in Boston, where they looked at the correlation between both diameter stenosis severity and then extent of plaque using the segment involvement score. And what they found that it did help risk stratify. So their outcome of interest was survival free from CV death or myocardial infarction. And what you're seeing on the Kaplan-Meier graph here is looking at the colors. They indicate both segment score as well as obstructive plaque. So the green was the highest event-free survival is people with no coronary artery disease at all. And pretty much superimposed on that is people who've got non-obstructive CAD with a segment score of less than 4. So basically mild plaque and a limited extent. So nothing obstructive and it's not extensive. In red is people who've got, or rather in orange is people who've got non-obstructive disease with a segment involvement score of greater than 4. So this is people who've got strictly mild disease, but it's extensive. And you can see that their events-free survival was less. And then in red is people who've got obstructive disease with a low segment score. So you've got severe stenosis, but limited atherosclerotic extent. And then in black, the worst outcome was people who had both high-risk features. So you've got obstructive plaque and extensive extent. So high segment score and high stenosis. On the Kaplan-Meier curve shown here from this study was looking at, again, survival free from MACE, where you've got...
Hey there, we've set your course to our voice message system, 6, 4, 7, 8.
You've got people with extensively mild plaque, so this is all non-obstructive, and what you see is that the event-free survival was much worse when the segment score was greater than 4. So if you had extensive plaque, even if it's non-obstructive, you did much worse than the people who had either no plaque or just mild plaque that was limited to less than 5 segments. And then the interplay between extent of plaque and severity of stenosis is shown nicely in this bar graph, where you can see that if you've got in the dark yellow here, non-obstructive plaque, but it's extensive, their hazard ratio for CV death or MI is essentially identical to people who've got obstructive plaque, but it's limited. So if you had one of the two, in both cases, you had about a 3-fold increase of adverse events. So severe disease in a stenotic standpoint, but limited extent of plaque, or no obstructive stenosis, but extensive mild plaque. And then the people who did the worst who had the both of them. So severe stenosis as well as a wide extent of plaque with a segment involvement score of 5 or more. So a simple tool to get a sense of plaque extent, and it is prognostic, but now there are more advanced ways to analyze plaque extents, especially with some of the more sophisticated software that's being available to institutions. And so there's now advanced plaque quantification software, and with AI techniques, they allow for a full CT assessment and quantification of plaque in the coronary tree, and they provide measures of the total volume of plaque, as well as stratifying it into plaque subtypes, where you have non-calcified, calcified, fibrous, fibrofatty, and low attenuation. And this is an example of what you're seeing here on this diagram, where this is a outline of an LAD, and what you see in the red here is this is soft plaque being picked up by the automated software. And then in this zoomed view here, and in panel D, and this is the zoomed view of the mid LAD, and in the red here, this again is soft plaque, and these islands of orange in here, this is area of low attenuating plaque. So low, very low Hounsfield units indicating areas of likely necrotic core plaque. And this plaque assessment has shown to be prognostic. So this was the CAPIRE study, came out in 2020. So this was a multi-center prospective study of 544 consecutive patients who had a CTA for suspected coronary disease. And they did quantitative plaque analysis looking at total plaque volume, as well as plaque subtypes. So soft plaque, in other words, non-calcified, less than 150. And then amongst those soft plaque, you look at fibrofatty, so 30 to 150 Hounsfield units versus low attenuation, where you're less than 30, indicating necrotic core. And what they found was that the amount of non-calcified plaque volume, and so they had a threshold here that was found to be an inflection point of greater than 80 cubic millimeters. So that amount of plaque volume of soft plaque was the most powerful predictor of combined MACE endpoint of ACS, CV death, and late revascularization more than 6 months out from your CT scan. And this non-calcified plaque volume outperformed both traditional risk factors as well as stenosis severity. And what you're seeing on this diagram, if you look in the middle here on this top panel, you have ACS plus cardiac death as your combined metric. And here they're looking at the performance of, again, non-calcified plaque volume versus multi-vessel disease. The red line at the top with the very, very good, basically 100% event-free survival, were those people who had neither multi-vessel disease or high non-calcified plaque volume. The people who were the next lowest risk were people who had multi-vessel disease, but again, a low amount of non-calcified plaque volume. Higher risk out from that were people who had non-calcified plaque volume of a high extent, but did not have multi-vessel disease. So therefore, you were more likely to die or have ACS if you had a high burden of non-calcified plaque versus whether you had multi-vessel disease. So the plaque volume was a stronger predictor. And then if you had both, that was your highest event rate. On the bottom row, again in the middle, same concept. So looking at ACS with cardiac death, but your comparator to plaque volume in this group was not multi-vessel disease, but rather Framingham risk score of greater than 20. So basically high risk factor burden. And same thing, if you had a high amount of non-calcified plaque volume, you had a high increased risk of adverse cardiac events, even if you were a low Framingham risk or not a high Framingham risk score patient. And then if you had both, you had extremely high incidence of events. So high plaque volume was more predictive than having a high traditional risk factor burden. The Scotthart study, which we spoke about earlier when we looked at the high-risk plaque analysis, high-risk plaque features, also had a sub-analysis looking at quantitative plaque analysis and its impact on 5-year MACE. And what they found on their multivariable analysis was that the burden of low attenuating plaque was predictive. So a low attenuating plaque burden of greater than 4% was the strongest predictor of MI. And this was irrespective of stenosis severity, of calcium score, or of clinical risk factors. And that's what you're seeing on this Kaplan-Meier curve. The red line is people whose low attenuating plaque burden is greater than 4% compared to the blue line where it's less than 4%. And again, this is felt to be the highest risk soft plaque because it represents a component of necrotic core. Now, moving on from plaque assessment, what about assessment of inflammation and the level of inflammation occurring at the actual vessel level? Well, it's well established now that vascular inflammation is a key feature in atherogenesis because it precedes both formation of plaque as well as plaque rupture events. Reducing the residual inflammatory risk has been shown to reduce MACE independent of LDL lowering in the CANTOS trial, where they used a monoclonal antibody against interleukin-6. And then, it's felt that non-invasive detection of vascular inflammation would allow us to detect and target very high-risk patients, and it would be sort of a holy grail of risk stratification. There are, indirect ways to get a sense of vessel inflammation. So, of course, CRP or high-sensitive CRP, but this is not perfect because it lacks specificity for the vasculature. It's not necessarily a vessel-level biomarker. You can use combination of PET-CT imaging to look at FDG and see inflammation at the vessel level, but this is expensive and it's not widely available. And then again, if you look at calcium scoring, well, this detects plaque in the vessel, but it's looking at irreversible damage. And when you put people on statins, we know that the literature shows that this tends to increase calcium scoring because it increases the amount of calcified plaque as you shift from soft to calcified. So it's actually not helpful for secondary prevention. So calcium scoring is useful to make the determination whether someone has atherosclerotic burden there or not, but it's not something you can use as surveillance or to gauge responsive therapy because it does go up when people on statins. So it's not a helpful metric once you put someone on medical therapy. So here we come to an interesting concept, which is now a sort of newer area in CT imaging and looking at vascular biology and inflammation at the vessel level. And this is taking advantage of the perivascular fat. So this is the fat surrounding the coronary vessels. And there's been some really groundbreaking, excellent work done out of the University of Oxford, where they've got a very busy group here that's done some really groundbreaking stuff looking at this and seeing its utility in terms of risk stratification. And so the perivascular adipose tissue, so that fat around the coronary arteries, actually communicates so in a bidirectional fashion with the adjacent blood vessels, so in a paracrine fashion. So there's signaling from the perivascular fat into the vessel and also signaling from the vessel into the perivascular fat. Initially, the thinking was that it was one way, so from the fat into the vessel, but it was determined with animal models that it's actually bidirectional. And this was seen that if you induce wire injury in a coronary artery, what you get is pro-inflammatory changes in the perivascular adipose tissue via TNF-alpha signaling. So it will actually change the phenotype of that fat. So inflammatory molecules such as TNF-alpha and interleukin-6 that are released from inflamed arterial walls actually diffuse out into the perivascular tissue, and they induce lipolysis as well as decrease adipogenesis, so reduce the actual formation and differentiation of new fat cells in this tissue. And so it invokes a sort of local cachexia type response of this perivascular fat to the vascular inflammation. And with the response, you get a reduction in the size of the fat cells or adipocytes, and you get a gradient in the lipophilic content of the tissue around the vessel wall. And this is shown in the bottom part here, where if you look at a normal vessel, and so non-inflamed, as you go out from the start of the vessel and go outwards, the size of the fat cells or adipocytes is fairly constant. And this is distinct from an inflamed artery, where as you go out from the vessel wall, away from the vessel, you have smaller fat cells that tend to get bigger as you go distant from the wall. So there's a gradient in the size of the adipocytes, and there's also a gradient in the lipid content, or the balance between lipid and aqueous. So an inflamed vessel, as you're close to that wall, you actually have less lipid content, more water, and then the ratio of fat to water increases as you go out from that wall, whereas the composition is fairly constant in a non-inflamed vessel. We have a high amount of lipid content, less water. So inflammation in the vessel causes these phenotypic characteristic changes in the perivascular tissue, where you've got a gradient of small adipocytes and less lipid content close to the vessel, and then increases as you go out from it. So the vascular inflammation drives a predictable phenotypic change in the perivascular adipose tissue that can actually be exploited through imaging to get a sense of what's going on at the vessel level with respect to inflammation. And here we have the concept of the fat attenuation index, or FAI. So FAI is a novel CT metric that relies on the concept that inflammation-induced changes in adipocyte size and lipid content are associated with a shift in the CT attenuation towards a less negative Hounsfield unit range. So you have a defined range of Hounsfield units, and as you go higher up, this indicates more inflammation. So at the highest scale is minus 30, and at the lowest scale is minus 190. So the more inflammation you have, the less negative your number will be. So the higher, the more towards minus 30. And so there's proprietary software that was developed at the University of Oxford that captures these gradients in the attenuation of the perivascular adipose tissue. And so the higher the FAI number, the higher the inflammatory burden at the vessel level. So that being said, using machine learning and artificial intelligence modeling, you can then robustly quantify vessel inflammation and predict cardiac risk. And so you're seeing here in this figure that as you become less negative, the color goes from yellow to orange to red, and this is seen then in the CT software analysis of this perivascular fat. So if you look at patients in acute MI, you see more red in the surrounding tissue around that vessel in the culprit lesion, as opposed to the non-culprit lesion, which is presumably not inflamed. And also, if you look at stable CAD and untreated plaque, you're seeing quite a predominance of yellow, not as much red. Whereas when you stent, and so you're now irritating, causing local inflammation from the irritation of that procedure, you're seeing more red. So the perivascular signaling in the fat around that vessel gives you a sense of what's happening from an inflammation standpoint at the vessel level. And studies have shown that in ACS patients, the fat attenuation index is significantly higher in the culprit vessels compared to other arteries, and tends to come down weeks later. And also in this diagram, you can see that the yellow there is that perivascular fat. And basically, what you're doing is taking sampling of concentric circles a millimeter out at a time to look at that gradient in attenuation. And so as you go farther from the vessel wall, your attenuation will come down. The adipocytes will go from smaller to big. The lipid content will go from less to more. So a very interesting novel concept and finding, but is it useful for risk stratification? And this was tested in a large study published in 2018 called the CRISP-CT study. So this was a multi-center study of 2 independent cohorts undergoing clinically indicated CTA for suspected coronary disease. And in this study, the goal was to investigate the utility of fat attenuation index mapping for cardiac risk stratification. Their endpoint was all-cause as well as cardiac mortality with a mean follow-up of 72 months. And what they found was that increasing FAI values were strongly associated with increasing mortality. And this was incremental over age, risk factors, and extent of coronary disease. And in this study, what they were able to do was find the inflection point. So what was the sweet spot? What was the number that above which was predictive? And they found in their derivation cohort that a cutoff value of -70 was identified as the inflection point that was predictive. And this was confirmed in the subsequent validation cohort. And so they found that if you had a FAI value of greater than -70, there was a 6 to 9-fold higher adjusted risk of cardiac death in these two independent cohorts. And this is what you're seeing on the Kaplan-Meier figure here. So in panels A and B, this is the derivation cohort looking at all-cause mortality as your endpoint in panel A and cardiovascular mortality in panel B. And in both of them, if you were had a FAI value of greater than -70, your event rate was much higher. And then panel C and D was the subsequent validation cohort, and they found the very consistent finding that a FAI value of greater than 70 strongly predicted increased mortality, both total mortality and cardiac mortality. Furthermore, they looked at the relationship between high-risk plaque features and FAI index. And what they saw here was that in the presence of a low FAI, so low degree of inflammation, high-risk plaque features no longer increase mortality. But in high FAI patients, again, there was increased mortality, and particularly if you had a high-risk plaque features. And so if you look on the right at this Kaplan-Meier graph, the red line is your reference of low FAI and no high-risk plaque. The green line is low FAI and the presence of high-risk plaque, and they're almost superimposed. So they're both had quite a low hazard ratio for cardiac death. Your blue line was people who had high FAI and no high-risk plaque, and a significant jump up where now you're seeing a marked increase in your hazard ratio for mortality. And then the highest risk cohort was, of course, people who had both high FAI and high-risk plaque features. So it seemed that the degree of inflammation very much influenced whether high-risk plaque features were going to be predictive of mortality. And that actually dovetails nicely with previous findings showing that high-risk plaque, even though they were specific, they weren't necessarily sensitive. And so it seems that the more powerful predictor of events is what the inflammatory milieu is like at the vessel level. And if you are inflamed, then if you've got high-risk plaque features, you particularly have a higher propensity to events and to death. Now, there was a subgroup analysis of the CHRIST study where they looked at the impact of medical therapy. And so what they found was for those patients, because again, these were all people clinically referred for suspected CAD, in that cohort, those patients who were advised to go on statin or aspirin were compared to those who were not. And they found that FAI was no longer predictive in people who were put on aspirin or statin compared to those who were not. And the feeling there was that it looks like probably the impact of your medical intervention is reducing your event rate. So again, this is a subgroup, but it sort of builds a narrative that the risk can be mitigated by your intervention of medical therapy. And that being said, what about, in general, looking at what does the literature show about CTA's ability to predict and evaluate the impact of medical therapy on patients? So this is data from the PARADIGM study, looking at statin use and its impact on plaque. And so the PARADIGM study sought to describe the impact of statins on individual coronary plaques. It was a prospective multinational study, and it was a registry of consecutive patients who had serial CT scans at interscan intervals of at least 2 years or more. And the average was both just under 4 years, 3.8 years. And what they found here was that statins were associated with increased plaque calcification. So the statin arm versus the control also had a 21% decrease in percent atheromal volume, so less total plaque, and a 35% decrease in high-risk plaque development, so less propensity to develop high-risk features. So the increased calcification is basically making the case that statins are converting soft plaque to calcific plaque, and therefore going from a more unstable, event-prone type of plaque to a more stable, to a less stable, more event-prone type of plaque, which is soft, to a more stable, less event-prone type of plaque, which is the calcific. And this is what you can see in this diagram of this vessel here. You've got on the left statin naive patients before and after in this cross section, and then statin taking patients. And you can see in the statin taking patients on the circle in the top there, the green is the degree of plaque, and so you can see that that degree of soft plaque volume is considerably smaller and is much more white. And so on your subsequent scan in your statin patient, you've got less soft plaque and much more calcified plaque, which again is the more stable phenotype. It's what you want. And that's why calcium scoring is not helpful when you've got people on statin, because if you scan them years down the road, your calcium score is probably going to be higher, and people scratch their head and say, well, that doesn't make sense. High calcium scores correspond with increased risk. But the reason it's higher is that you've actually taken soft plaque, converted to calcified plaque, and therefore reducing your risk of events. So it's actually indicating a helpful change in morphology, but it's not useful to follow patients because that calcium score is not useful once you're on a statin, because you know it's going to go up. But essentially, statins will convert the plaque to a more stable phenotype with increased calcium and less high-risk plaque features. What about aspirin? Well, this is data from the MESA study, and they were looking at aspirin as primary prevention and what's the risk of benefit ratio, looking at number needed to harm in terms of causing an adverse significant bleeding event versus number needed to treat in terms of looking at reduction of ACS. And what they found here was that calcium score was actually quite useful to stratify. So in all these figures, the red line running across is the threshold for harm. So once you go above that red line, now you have excess harm, excess bleeding events. And so the three groups are basically people who had low ASCVD risk, so less than 5%, intermediate, 5 to 20%, and then at the right, high risk, so greater than 20%. And so the light green is people with a calcium score of 100 or more, and the dark green is people with a calcium score of greater than 400. And in all these groups, whether you were low, intermediate, or high risk, if your calcium score was in the greens, you had excess benefit. So aspirin was a net positive intervention, reducing MACE events. Whereas you can see if your calcium score was 0, so that's the orange, there was net harm. So you actually ended up having aspirin being a net harmful intervention because your risk of bleeding far exceeded your benefit. So baseline risk as stratified by calcium scoring helped you predict which patients are actually more apt to benefit from aspirin as opposed to be harmed. This is a study looking at impact on statins based on coronary calcium scores, and the outcome of interest here was 10-year MACE, so cardiac death or MI. And what they found here was that the impact of statins tended to be very much dependent on baseline calcium score, where on the top left, this is people with a calcium score of 0, and red is the statin group, blue is no statin, and the lines are pretty much superimposed. There was no difference in 10-year event of MACE. In the top right, this is now a calcium score of 1 to 100, so very modestly elevated, and you see really minimal separation. Compare that to the bottom panels where you have calcium score of greater than 100 to 400 or more than 400, where you see really quite a separation, where the statin-taking patients in the red had a much lower event rate compared to the blue, which was not on statins. And when you work that out to number needed to treat, what they found was that basically, if you had a mildly positive calcium score, so between 1 and 100, to put people on statin therapy to reduce events, the number needed to treat for 10 years to reduce one MACE event was 100. Compare that to if your calcium score was greater than 100. then the number needed to treat drops to 12. So a dramatic impact on your power of your intervention, a dramatic difference based on calcium score. So a much more robust impact if you've got more calcium compared to minimal. So the higher your baseline risk, the more potent your intervention in terms of benefit. This is data looking at the impact of icosapent ethyl on plaque progression. So this was the EVAPORATE trial. So these are all patients who are on statin therapy and have high triglycerides. And what they found here was when you looked at CT at baseline and then at 18 months and looked at your impact on plaque volume, there's quite an impact of the icosapent ethyl, where on the left here, they're looking at low attenuation plaque. So this is, again, the highest risk plaque, that less than 30 Hounsfield units with necrotic core that tends to have a high tendency to cause plaque rupture events. The icosapent ethyl group, over the 18-month period, on the subsequent scan, there was a 70% reduction in the burden of low attenuating plaque. Compare that to the placebo arm, where the amount of that plaque almost doubled, or more than doubled. There was a 109% increase. So this medical intervention had a significant reduction in the highest risk plaque, showing the effect of this at the vessel level, which one could speculate may indicate the mechanism via which event rates are lowered by icosapent ethyl in these higher risk people. And again, this is on a background of already statin therapy. And what about FAI, which we talked about? We've shown that it predicts mortality, but can it be modified by anti-inflammatory interventions? Well, it's never been tested in a randomized controlled trial, but it's been hinted at or alluded to in a study that was published in 2019, where they looked at 164 patients with moderate to severe psoriasis. And they did a prospective cohort study of these patients who were all at baseline not on biologic therapy. And what they wanted to compare was those patients who were treated with biologics, so looking at agents that antagonizing TNF alpha or interleukin 6, versus those that were treated with non-biologic therapy, so either light or topical therapy. And they found here that biologic therapy was associated with a significant decrease in the FAI at 1 year, and that was concurrent with improvement in the skin condition. And then when they look at those people who were treated with the non-biologics, there was no change in their FAI. And this diagram of the vessel here on the left, at the top, you're seeing baseline and 1 year follow-up. And the top panel is a high responder patient. And you can see that the amount of red at baseline is significantly lessened and is much more yellow, corresponding to a lower FI index, less inflammation, higher lipid content. In the middle is a modest responder at baseline and at 1 year. So you're seeing, again, more yellow in that subsequent, so that the index is lowering, it's becoming more negative. And then the bottom was a weak responder, so not very different. But in the high responder and even in the moderate, you see a clearly visually striking change in that attenuation index, indicating less inflammation in response to these biologics. And the impact of downstream management on medication after CTA can also be alluded to, and this is data looking at the Scott-Hart study. So again, this was a study looking at patients with chest pain syndrome being evaluated for suspected coronary disease, standard care, so traditional stress testing versus CTA. And what you saw here was the outcome of interest in this study was death from coronary disease or non-fatal MI. And the blue arm, so CT arm, significant reduction in the incidence of that endpoint over 5 years. Importantly, this reduction was achieved without any increase in the rate of cath or revascularization, and thus making the narrative that it's likely the benefit is being attributed to the medical therapy that was enacted on the basis of CT results. So the information about presence of plaque probably triggered the initiation of medical therapies that ended up leading to a reduction in adverse events. And I just thought I'll pull up a case because I actually was reading CTs last week, and I saw a case that actually made me think about some of this literature that we've been examining. And so this was a gentleman who was 56 years of age. He was being referred for exertional chest pain. He had a positive family history for premature coronary disease. He was a non-smoker. He was on no meds, and he had been worked up with a prior SPECT scan. We weren't told what the results were, but presumably it was equivocal or not clear because he was sent for this CT imaging to further risk stratify him. And here's a CT scan. So what you see is that on the left here, he's actually got a very tight or obstructive stenosis in the ostium of a pretty large first diagonal branch. His diagonal is fairly downstream in the vessel because he's got a ramus, but so that's his D1, and he's got a tight stenosis at the ostium. But distal to that in the LAD, if you can appreciate, he's got a mild plaque. It's a mixed plaque, so it's got some calcification inside soft plaque. And on the right here was us looking at this non-obstructive mixed plaque in cross section, and what this plaque had was, interestingly, it did have features of vulnerable plaque. So it had spotty calcification in it, and it actually exhibited positive remodeling where it was outpouched in compared to the adjacent segments. So a non-obstructive vulnerable plaque, in addition to a severe stenosis in his D1 that was probably causing his typical angina. He had minimal calcification. His calcium score was only 1, but again, the report, we indicated he had a severe osteal D1 stenosis, and then a mild mixed plaque in the distal LAD with features of vulnerable plaque, namely spotty calcification and positive remodeling. So his CAD-RAD score was 4 because he had obstructive disease, and we put the qualifier 4V because it was he had vulnerable plaque in his coronary tree. His segment involvement score was only 2 because he actually only had 2 segments of plaque in that D1 and in that distal LAD. So if we were going to try and see what the literature would say about his prognostication beyond just mere diameter stenosis, again, looking at the data out of the Brigham from Bittencourt and his group, well, this fellow has the combination of obstructive CAD, but he's got a low segment score. Segment score is 2, obstructive plaque. So that would correspond in their analysis to a 3-fold increase in the risk of death or MI over 3 years. If you looked at the Scott-Hart data, this fellow's got high-risk plaque and obstructive disease. So he's got the combination of these 2 high-risk components. And that, in their study, conferred a 10-fold increase in the 5-year event of MACE. So when you go beyond stenosis, you can get a better sense of the impact of these other features you're seeing in terms of risk of downstream events. Now, his risk could probably be further refined if we were able to quantitatively assess his plaque burden and perhaps subtype it, or again, if we had the ability to look at what his inflammation status was at the vessel level using FAI, because again, we saw from the CHRIS study that if your FAI is low, if your vessel is non-inflamed, then the high-risk plaque features actually didn't confer increased risk of mortality. So this diagram is just sort of a schematic looking at all the different ways that CT can be helpful to assess for coronary artery disease. And I think it's a very exciting time for this modality because we're seeing it's not just an angiogram surrogate for looking at luminal stenosis, but you can actually take a tripartite approach of looking at coronary lumen assessment through the contrast study, as well as if you also have other software, you can look at CT-FFR or even perfusion. And then through number 2, looking at plaque evaluation and quantification. And then 3, getting a sense of the perivascular assessment for inflammation at the vessel level. And using these 3 arms, you can maximize the prognostic impact of CTA. That being said, further research questions remain, such as, what's the best medical therapy to modify plaque, to reduce inflammation, or to reduce events in high-risk patients. These have been alluded to in some cohort studies, but not really rigorously assessed in a randomized controlled fashion. And likely that's coming in the future. So stay tuned. I think the literature will continue to teach us and guide us in how best to manage these patients. And I'll take any questions. Thanks for your attention.
Thank you, Dr. Galawango, for that presentation this morning. We'll quickly go into the question answer period. If anyone has any questions, please ask Dr. Galawango either using the raise your hand, or you can just type it into the chat.
Hi, good morning. I have a quick question. It's Kibar. Hi, Paul. Great talk.
Hey, Kibar.
I just want to hang on a piece of information you gave towards the end of that case you presented, where the negative FAI or the low FAI negated the high-risk features of the plaque. So my question to you is FAI strong enough to negate those features, or does it simply modify your risk assessment when you look at plaque composition?
Yeah, good question, Kibar. My sense is the FAI is more powerful because it's actually looking at inflammation, and so I think if you've got high risk plaque, that's not telling you anything about sort of the sort of inflammatory state of the plaque. It's just describing the phenotype, right? So it's saying you've got most likely thin cap atheroma, which may have a higher propensity to plaque. So that, I think of it as sort of like a two-hit hypothesis. So you've got, load the gun and pull the trigger. So the gun's loaded with that high-risk plaque, but its actual active inflammation is going to pull the trigger and cause the rupture event. And that's why I think FAI is driving the impact of high-risk plaque, because if your vessel's inflamed, then that thin cap fiber atheroma is likely more apt to rupture and cause an event. Whereas if your plaque or your vessel is stable and not inflamed, the gun is loaded, but the trigger is not pulled. So I think it's the inflammatory status that actually dictates whether your high-risk plaque is going to rupture. So I do think it's the more powerful predictor.
And is FAI slowly becoming more mainstream, or is it still at Oxford?
No, it's not mainstream. So it's been mainly in these like quaternary centers, research labs. It takes about 45 minutes to do it, so it's far from ready from prime time. But I think as the data comes out, hopefully they'll these vendors will make a more user-friendly, faster way to do it and have it rolled out. So I suspect in the next 5 years or so we'll start to see it. But right now, it's largely in research labs.
Great, thank you.
Yeah.
We have a couple hands up. First, we'll go to Dr. John Mohammed, then Dr. Burstein. Dr. John Mohammed, got a question?
Yeah. Thank you very much, Paul. Great talk. Thank you for the review. And Kibar asked some of my questions. But going back to your case, in addition to the questions Kibar asked, what is the strategy in terms of managing that patient? Is that patient now seeing a significant diag territory to be managed with intervention with the PCI of that vessel? Or just seeing the, if that wasn't there and you saw what you saw in the LAD territory, very aggressive medical management only with no interventional approach, despite the symptoms the patient's been having?
Yeah, good question. So, I mean, remember this fellow's being referred for typical angina, and I suspect his symptoms are probably driven by that diag stenosis, because it actually is not a trivial vessel. It's a good sized branch. And so, I think if his symptoms are compelling enough, likely benefit from intervention to stent from a symptom standpoint. But for medical therapy, to modify his risk of events down the line, knowing that he's got this phenotype of both obstructive disease, high risk plaque, confers a higher event rate years down the line. I think he needs aggressive medical therapy. And so obviously, clearly, I think aspirin and statin, but your question is good in terms of what else. And this is what I think the literature will hopefully show us, because it's an exciting question in terms of, okay, aspirin and statin is easy, but if you've got people that got really high plaque burdens or lots of soft plaque, lots of low attenuating plaque, do aggressive therapies above aspirin and statin modify event rate. if you've got people with high FAIs and lots of inflammation. So things like, I think, icosapent ethyl, the monoclonal antibody against interleukin 6 that was looked at in the CANTOS study, maybe, like COMPASS type patients where you're giving low dose anticoagulation on top of antithrombotics, sort of the sort of higher degree of medical therapy. Is there a role for that in these people who've got more and more plaque and higher risk plaque? So I don't think we know yet, but I think it's going to be an active area of research, what to do to these people to minimize their risk.
So as a corollary, in our patients who have sort of not completely normal, but not completely abnormal, non-invasive tests, should we be strategizing by getting CT on these patients to look for some of these higher risk features, and then using that as an arbiter for more aggressive treatment? And as an addition, if you were to do that, do you have the capacity to accommodate that many more tests, which is going to be always the elephant in the room?
Yeah, in a word, no, man. We're struggling already, but I think we're kind of, the patient population you described, we're already seeing, right? Because the people who come for CT are those people who've got, equivocal or unimpressive non-invasive tests. That's why they tend to be sent. So that's the group that we tend to see already, and that's the group that tend to be studying these trials, where sort of clinically suspected but not sure for CAD. And so, I think the message of this talk is that when we send them for CT, typically we've been focusing on diameter stenosis, and we're trying to say, okay, is your funny pain caused by stenosis or not? And if it's not, often we say, okay, you're going to be fine, maybe some statin or aspirin if there's plaque. But now that we're able to sort of get more information as sort of the actual morphology of the plaque, the propensity of plaque to rupture, the level of inflammation. I think apart from looking for diameter stenosis, we're also now able to stratify people based on these other features and get a sense of, okay, you may not have obstructive disease, but you're high risk because of X, Y, and Z. And now we want to know what interventions can modify that risk. So, I think we're able to now take advantage of all this other information we're seeing, but the question is, okay, and what do we do with it? And that's where it's an exciting time for research.
We've gone overtime, or can I pick your brain a bit, Paul?
Sure.
Couple comments. I got 20,000 people watching Leafs games. Maybe we should do these in person. It'd be nice to see some faces besides Zoom. Wonderful talk. You become a real expert in not only CT, but atherosclerosis. And it's really nice to have someone like you, and I'm sure some of our other group, non-invasive group. While I was driving and I was listening, looking at all your slides, couple things. There's a lot of contradictions in the sense that maybe I just don't understand it, but calcium score initially you said trumps all, statins cause more in terms of events, calcium's cause more, statins cause more calcium, that's protective. And then when you look at lesions, if they are low Hounsfield units and soft and necrotic, they are higher risk. So when you try to put that all together, it sometimes can be a little bit confusing. So for example, for me, those plaque morphology cases where they're higher risk, i.e. low Hounsfield units, not a lot of calcium, do those patients have very high calcium scores? Because otherwise it's really hard to kind of reconcile all of this. You know what I mean? Do you understand what I'm trying to say?
Absolutely. There's a lot of different messaging. Sometimes it's hard to say, is this all consistent? So when I talked about calcium score trumping all in symptomatic patients, that was in a study where they were looking at calcium score, but they're looking at high risk plaque features, but they weren't looking at quantitative plaque analysis. And so that's why my thinking was that calcium score was more predictive than high risk plaque features, because calcium score was a surrogate for total plaque. Because as your calcium score goes up, as the amount of calcified plaque goes up, all plaque is going to go up. So I think it was a crude marker for total plaque, which would include even the vulnerable, low attenuating plaque.
I think that's how you have to marry the two together.
Yeah.
Yeah, it's fascinating. The amount of data is just exploding. The RCT data hopefully will flow in, because one of the points I will make out has become more confusing than ever to what is primary versus secondary prevention. And just yesterday, the big United States task force said, don't give aspirin to anyone, especially if you're over 70 or over 60. And of course, what is primary prevention today, right? Because and so it's really just a comment, but as you know, you showed a lot of, I think it's non-RCT data that suggests if your calcium score is over 100, take an aspirin and a statin. But the truth is, primary prevention is somebody who's never had a heart attack or stroke or angina, but they may have a calcium score of 1,000. So my only point is it's very confusing, and it would be nice to see some proper RCT data that says, okay, let's take, I don't know, plaque burden or calcium score and randomize these to these medications. So as a practitioner, we have a better sense of what to do, because just good old-fashioned aspirin has never been more confusing.
I agree. I think, with the sophistication of the imaging we have, it does make it confusing. What is primary prevention? Like if someone who's never had an event, but they've got a calcium score of 800, or that they're full high risk plaque, is that really someone you'd leave alone? So it's true. We need probably controlled trials where you've got people matched by these imaging modalities to know how to manage them, because it's kind of the Wild West. And a lot of it is inferring, but hasn't been done in sort of rigorous trials to test these hypotheses of the impact of our therapies.
Thanks for your efforts. Great talk.
Thanks a lot.
I think our last one is going to be Dr. Ritchie.
Hi, Paul. Thanks. I really enjoyed that. I just wanted to comment about the data, because I agree with Jason on one level. It's confusing, but I think after the pathology stuff that you alluded to from ischemia and complete trial data after did show, I think what it was clear, and I think how this is all brought together is that patients aren't one or the other, meaning stable non-inflammatory plaque versus inflammatory plaque. They're a mixture of lesions that are in various stages of inflammation or resolution, and the risk has to do with that ratio. So that's why I think the complete trial probably identified that high-risk acute lesions benefit from intervention, but the stable ischemic patients do well long-term. And I think the data is consistent with that, and meaning that if there are markers that show overall risk of instability, like some of these newer techniques show, they actually probably reflect why aggressive second preventive interventions are so positive. It's not because they cure every lesion, but because they shift the balance away from these higher risk inflammatory lesions, so the proportion of them is less, so the outcomes are better. And the other comment I was going to make, and I'd like your interest in your thoughts, is that the primary prevention definition in the U.S. is confusing, but in trials like HOPE and most of the secondary prevention trials, secondary prevention included any patients not with an event, but with objective evidence for coronary disease. So for instance, in the HOPE cohort, secondary prevention or high-risk primary prevention, which gets rolled in, included patients who had clear documentation of coronary disease, but they may not have had an event, whether they had an angiogram or abnormal perfusion scan or clearly positive stress test. And that is confusing in the lay public, and it is. But I think medically speaking, my comment would be that we, as cardiologists, we should be treating people with documented vascular disease in any territory as secondary prevention, because it really isn't primary prevention. And I think the messaging on that's been pretty confusing.
Yeah, it's a good point. I believe in HOPE. I think their CAD cutoff was 50% or more on cath, if I remember correctly.
You could have an abnormal perfusion scan. Anything that made you high probability of coronary disease or with documentation of coronary disease. So an abnormal perfusion scan and typical history you could get in. Abnormal cath, you could have a carotid stenosis over 50% without an event. Like there were, but my point is that that kind of data needs to be looked at, because those are high risk populations, right? They have vascular disease. They haven't had an event.
Yeah,
but they're going.
I think it gets tough because sometimes the variable is continuous, right? So we like to think of binary. Is it there or not on imaging? But is a calcium score person of 800 the same as someone of 18? They both have plaque. And where's where you draw the line as to who you think needs treatment. So it gets difficult as our methods are more and more sensitive. We can see smaller and smaller degrees of plaque as to, okay, well, who would actually qualify as someone who's got documented disease in some of these older studies. And that's why, for me personally, I see a calcium score of 100 or more as higher risk, because a lot of the studies tend to show increased event rates above that. But it's never been tested sort of in randomized trials as to what's your cutoff and how much plaque that you're visualizing is necessary before you see impact of intervention. So it is a bit unclear right now.
Yeah, and I think that's the problem we make, because we see the world binary when it's not.
Yeah.
So it's kind of analogous to the focus we used to have on stenosis severity versus all these other factors that play into risk, including risk factors. We need to shift away from that to a broader view of risk, right? And
it's fascinating. The more we learn, the more questions arise. So it's an exciting field, though.
Thanks very much. It's great. That was really a great presentation.
Thanks a lot.
Thank you, Dr. Gallo-Wango, for presenting this morning. We'll end it here. Thank you, everyone, for joining us this morning. And I'm not sure if we have one next week, but hopefully we see everyone back on our next cardiac rounds. Take care and have a good one.
Thanks.